And next presenter is Dr. Aurélien Dupre, and the Center Lyon Bird and the Insum and Unit Lab Tour. And he is the consult in surgical oncology in the Comprehensive Cancer Center of Lyon since 2013. And his clinical specialty is hepatobiliary and pancreatic surgery, minimally invasive surgery. And his research specialty is translational research and clinical research. And also he is the principal investigator in a multi-center phase 1-2 study about intra-operative HIFU ablation of locally advanced pancreatic cancer. And his topic today is intra-operative high-intensive focused ultrasound pancreatic ablation in a porcine model, the first step towards a clinical treatment of locally advanced pancreatic cancer. Let's welcome.
Hello, everyone. Thank you very much for your kind presentation, and thank you for the invitation. So let's begin. So as you know, pancreatic cancer is the major health problem. We have impressive incidence that is rising over the year. For example, in France, we had 5,000 cases per year in 2005. And recently we observed 14,000 cases per year. So it corresponds to an increase in 250% over the last 15 years. It is currently the fourth leading cause of cancer deaths, and we estimate that that will be the second cause of cancer deaths in the next 20 years. The prognosis is very poor, with a 5-year overall survival of about 6%. And unfortunately, only 20% of the patients are candidates to surgery, which is the only potentially curative treatment. And among those 20% of patients, less than 20% of those patients will cure from their pancreatic cancer. So it is clear that we need new treatments in our toolbox. Focal destruction techniques are very well known, and they are used instead of surgery in some patients. The technique is based on thermal ablation of tissues. The main representative of focal destruction techniques are radiofrequency ablations, microwave ablations, and they are not frequently used in pancreatic cancer. The focal destruction techniques have some limits. It requires the introduction of a probe into the tumor. It is subjected to the heat sink effect. That is, when you increase the temperature in tissue, when it is close to large vessels, you have a decrease in temperature. So you have a risk of under-treatment of the tumor when it's close to large vessels. And the rise in temperature is very high, more than 160 degrees, for example, with microwave ablation. So you can't have a per-procedural monitoring. There are some new, not very new, but recent ablative techniques to encounter those limits. For example, you have irreversible electroporation and high-intensity focused ultrasound, or HIFU. So what is HIFU? HIFU is a technique of focusing the ultrasound. You all know the ultrasound for diagnosis purpose. HIFU is therapeutic ultrasound. The principle is pretty simple. It's like when you put a magnifier glass to focus the sun rays to obtain fire. It's the same principle with ultrasound. You have a focal transducer which focuses the ultrasound, and at the focal point, you have an increase in the temperature to 70 to 80 degrees in a few seconds, and it results in coagulative necrosis. The main advantage of HIFU, it's a totally non-invasive technique, and there are some theoretical advantages. The phenomenon is very fast, so it looks like it's independent from the blood flow, and as the temperature rise very fast and not too high, you can have the possibility of real-time monitoring of therapeutic effects. But it's not a magical technique, of course. You have some technical difficulties. Here you have an example of the HIFU device that is used in China. It's an extracorporeal device, and the elementary ablation obtained with HIFU is the size of a rice grain. So if you want to ablate a large tumor, you have to juxtapose the rice grain to obtain a large ablation. So it requires long-lasting treatment. For example, for the treatment of prostate, you need more than 1 hour. And for the treatment of uterus fibroma, you need several hours. So it's clearly limiting the development of the technique. Some other difficulties are specific to the pancreas. This organ is very deep-seated, so you have difficulties to target, to visualize the organ, because you have interposition of the gas of the stomach and the colon. So you have bowel and gas interposition, which is not very good for ultrasound. And the other difficulty with the pancreas is the parenchyma of the pancreas that is very fragile, and you have a risk of pancreatitis. So the strategy of our lab research was to develop an intraoperative HIFU device which will be able to perform large ablation. So you have in the center here the HIFU probe that can be held with your hand. And here you have the probe. In the center of the probe, you have a ultrasound probe that is for targeting, for ultrasound imaging. And all around the US probe, you have the HIFU emitters. With extracorporeal device, the conventional transducer are spherical, and you obtain the ablation of the rice grain size. With our technology, we developed a toroidal transducer, and we were able to perform ablation of 7 cubic centimeters in 40 seconds and 50 cubic centimeters in 6 minutes in vitro study. We developed this device initially for the treatment of liver tumors, just because the history of my department was the treatment of colorectal cancer with liver metastasis. So about 10 years ago, we developed this device, and the use is very, very simple. You have the probe in your head, you put it on the surface of the liver, and you have on the interface this image. You have here, that is black, it's a coupling liquid. It's a balloon filled with water to facilitate the ultrasound beams. You have here the liver in gray, and you have the targets that represents the future area that will be destroyed, that will be ablated by HIFU. So if you want to treat a tumor, you just have to put the tumor into the target. We designed a prospective study several years ago in which 30 patients were included. The aim of the study was to ablate colorectal liver metastasis before liver resection. There was no modification of the surgical planning because when you treat well patients, there's a great chance of cure. So we did not want to risk a loss of chance for the patient. And in this study, we had some encouraging results. We were able to perform large ablations in 6 minutes, and we were able to monitor the real-time effect. For example, here on the top right of the slide, you have like triangle-shaped elementary ablation that we initially obtained in 40 seconds. And what is interesting is that with the real-time monitoring, it's very easy to juxtapose several ablation, and you have an example of juxtaposition of 2 ablation of 6 minutes, and you have a very, very large ablation. The other observation that was interesting was that HIFU ablation was not subjected to heat sink effect. For example, you have here an ablation all around hepatic vein, and you can see that the ablation is not modified, it's not shrinked by the blood flow. So we have clearly not demonstrated, but encouraging results with no heat sink effect with HIFU therapy. And our hypothesis was that this particularity would be great in the treatment of pancreatic cancer because you have a lot of big blood vessels all around the pancreas. Of course, you can ask what is the rationale for HIFU in pancreatic cancer, because as I told you, it's an aggressive disease, and most of the time it's a systemic disease with metastatic. What has been demonstrated is in Chinese studies is that HIFU is very effective for pain control. And in some reports of Chinese teams, they also observed a tumor volume reduction. They observed a reduction of 1/3 of the tumor volume at 3 months and 2/3 at 6 months. So that's very interesting. But we keep in mind that radiotherapy had the same objective several years ago and for local control, but only negative randomized control trials have been published with radiotherapy. Anyway, there is some opportunities because there are a few alternatives. Some teams, one team in the US use IRE, and one team in Italy use radiofrequency ablation, but there's a subpopulation of patients with locally advanced pancreatic cancer in which HIFU could be useful. Locally advanced pancreatic cancer are not non-metastatic tumors, but not resectable due to vascular involvement, mainly the superior mesenteric artery and the celiac trunk. You have here an example of a quite small tumor, but not very well placed. And if it involves the superior mesenteric artery, you can't resect it. So we made the hypothesis that using intraoperative HIFU, we could destroy this kind of tumor. Here you have an example of the pancreas in human and the CT scan slide corresponding. You have here the pancreas, and here the portal vein, here the mesenteric, superior mesenteric artery. Of course, we chose the pig as an animal model because the anatomy is quite similar to human as for proportion. And at the bottom and right of the slide, you have a CT scan slide. It looks similar as in human. You have the pancreas here. It's thinner than in human, but anyway, and you have here the portal vein and here the mesenteric artery. So it's very, it looks like human. The first step was to prove that we were able to do reproducible ablation and safe ablation in the pancreas. And we were afraid of having severe pancreatitis. And we obtained in the preliminary experiments in pigs, ablation of 2 by 2 centimeters without severe pancreatitis. That was the first step in our pathway, research pathway. The second step was to perform the ablation all around the mesenteric vessels. There's no tumor model in pig, but we were confident that if we were able to destroy the pancreas all around the superior mesenteric vessels, that would be interesting for humans. So we were able to perform ablations of 25 by 35 millimeters in 10 minutes. Here you have a CT scan imaging in a pig. You have here the ablation of the pancreas, and you can see that it encompassed the mesenteric vessels. Here you have the macroscopic view. You have the artery here, and you can see that the ablation is made all around this tissue. So that is very interesting. Of course, I show you the best picture I have, or quite the best, but it took several years to obtain these results, because at the beginning we thought that high energy delivering was a good option, but it was not the better option, because when we use energy deposition over 40 kilojoules, we had some arterial complication, such as arterial thrombosis, that is not possible if we want to translate these results into human. But when using energy below 40 kilojoules, we never had arterial thrombosis. We sometimes had arterial spasm when we did several ablation at the same spot. To increase the safety before clinical trial, we developed a real-time Doppler monitoring. Here you have an example of the pancreas that is here. You have the target in red that will be ablated by HIFU. And we had real-time Doppler monitoring to the interface. And it looks obvious to us to have Doppler with ultrasound imaging, but it has never been used in clinical practice with HIFU currently. So it was a good start for us. And we were able to visualize the blood flow during the HIFU procedure. And we developed an algorithm that is able to predict the occurrence of an arterial spasm 1 minute before its occurrence. So it's a safety element that is very important for us before using this technology in human. So in summary, at the macroscopic scale, we are able to perform ablation in the pancreas around major peripancreatic vessels. It is reproducible, it is safe. We are able to perform a Doppler monitoring while we destroy pancreatic tissue with HIFU. And what is for me very interesting is that we have the confirmation of tissue destruction all around the artery. We have destruction of the tissue, the plexus nerves in contact with the artery. So there are no heat sink effect. And it's obviously very interesting in locally advanced pancreatic cancer. So to conclude, it is a good example of translational research. We are able to do HIFU pancreatic ablation with an intraoperative approach. These ablations are reproducible, they are safe, and we design and obtain a grant for a phase 1-2 clinical study for the treatment of locally advanced pancreatic cancer. And I hope this study will begin in September 2022. Thank you for your attention.
Thank you. Professor Dupre has just tells the story about what is the HIFU and how does it works. So it's really very interesting. And actually, I know the HIFU is very safe and very effective because it has no heat sink compared with other techniques. So the pancreatic tumor is a life-limiting tumor. So with the rising incidence, so it has been paid more and more attention. And actually, the HIFU just can make the mass reduction, and also at the same time, it can just relieve the tumor-related complications. So it's really interesting. And in a word, it is an exciting and innovative technique. Okay, actually, as far as I know, just if we can do a pancreatic tumor model, animal model in situ, actually it is very difficult, is it? Yeah. So, would you like to say something about it?
Yeah. Actually, it's very difficult to have tumor model, especially in the pig. We try to develop tumor in the pig because for surgical experiments, the pig is a very, very good model because the anatomy with pig of 20-25 kilograms, you have quite the same anatomy for the liver, for the pancreas, but the main drawback of this animal model is that you don't have any tumor model. And as you see, our probe is quite very big because you hold it in your hand. So you have tumor model in mice, but it's too small for our intraoperative HIFU probe.
So it's tricky. And any other questions from other professors? Questions or comments? No? No? Okay. Shall we just leave 10 minutes for a short break? And actually, Professor Chen is now busy with his emergency event. So shall we wait him for 10 minutes and we will back, okay? Thank you.
Sorry, I have some question, maybe not question, it's some thinking of the HIFU procedure. Can I ask some questions to Dr. O'Helen?
Yeah.
Nice to meet you. Let me introduce myself first. And I'm a surgeon working in Shanghai Regional Hospital. But actually now I'm in the exchange program doing my PhD in CSL. I think you know this because we are working in the same campus. Same campus, and now sitting in my office in Chenede. So we are very close, and it's very interesting for the HIFU procedure, as you mentioned that you don't have a tumor model in pigs. And as far as I can understand it, as you have tried a lot of researchers in pigs, pancreas, so you might have already detect the feasibility and the safety of this procedure in pancreatic surgery. And as you mentioned that you have already applied for the phase 1 to phase 2 study in human PDAC patients, and it will probably start at the end of next year. Are you interested in some multi-center studies of this HIFU procedure? I'm asking this because, yeah, as I mentioned, I'm a surgeon in Shanghai Regional Hospital, and we exactly work on pancreatic cancer. And then we have a very high volume of patients. We perform pancreas surgery for more than 1,000 cases each year. So if you are interested in this multi-center clinical study, maybe we can do some cooperations. What do you think?
Mm-hmm. Thank you for your comment. 1,000 cases per year, it's very, very impressive at my scale. Yes, of course, it's that would be great. But honestly, we are beginning with a phase 1 study because we have to prove that it is safe to ablate the neck of the pancreas around the mesenteric vessels. Before using a multi-center approach, we have to prove that it's safe for patients, because if we have any complication with the superior mesenteric arteries, that will be dramatic. So the first step, the first 6 patients are for proving the safety of the device, and just after that we have a phase 2 evaluation with several centers in the area, several hospital, university hospital in Lyon, Clermont-Ferrand, and Saint-Etienne. But honestly, if it works, I would be so happy to have a collaboration with you. That would be great. And if you want to discuss it in the campus, that would be great.
Yeah, of course. I will definitely send you email for the connection. And as you mentioned that you are doing now the phase 1 to 2 study, it's mainly about the safety when you're treating with the SMA or SMV. Am I correct?
Yes.
And have you think about to start from the tail, body and tail of the pancreas in order to get rid of the impact of the vessels, because it will be more safety?
Not in human, because if you have a small tumor, it's difficult to propose to patient to perform HIFU ablation rather than a surgery that is a gold standard treatment with curative intent. So that one thing that could be done is that as we made in the liver, that would be ablation of the tail of the pancreas just before resection, but it's not so easy to find some patients who agree with that strategy. So I'm not saying that we are only treating patients with involvement of the SMA, and some patients with locally advanced pancreatic cancer have also celiac drug involvement, but we do not plan to treat patients with pancreatic cancer in the tail of the pancreas.
Yeah, I fully understand your point. What I mean to treat with the patient with the body and tail of the pancreas is mainly in the population of unresectable, I mean, a more invasive stage of the pancreatic cancer. Of course, you don't treat them with HIFU for the resectable cases. It will open a very wide range of topic for proposing by your topic. So maybe we'll discuss afterwards. I'm expecting to meet you. Thank you.
That would be great. Thank you very much.